Good morning. Welcome to day 2. How were the general sessions? I was in kids club making constellations. Are they good? Cool. So welcome to the EN session. I would like to jump right into it, and I will introduce Jody Wolf, who will be speaking about malnutrition.
Thank you, Maisie. Good morning, everyone. My name is Jody Wolf, and my background is I'm a registered dietitian, and I was in clinical practice for 25 years. And most recently, before coming to Baxter to work in medical affairs, I was able to care for pediatric consumers with special needs, complex medical conditions. And what I learned in my experience is that the caregivers, the consumers, they enjoyed learning about some of the ways to recognize some of these deficiencies. And that's what I'm going to talk about today, is identifying some of the deficiencies, recognizing some of these red flags for vitamin and mineral deficiencies, but also recognizing some signs of malnutrition. Now, I'd like to say that, in teaching this, I found the most effective way to teach this is through some photographs. And some of these photographs are from actual consumers that I cared for in practice. But these may be triggering some of the pictures, especially in the malnutrition portion. And if so, when I get to that malnutrition portion, I just want to be sensitive to that. And if you need to step out or anything, please feel free. My intention is just to share these things so that you know what to look for. So let's jump right in here and get started. So the learning objectives for today, I'd like you to be able to recognize the signs and symptoms of some of the common nutrient deficiencies. So I won't be able to touch on every single nutrient deficiency, but just some of the ones that occur more often. And then identify some of those physical signs of malnutrition, and then learn how to discuss these findings with your medical team. Some ways to, if you do see these, some of these signs, what do you do then afterwards? And so we'll talk a little bit about that today. So what are the causes of nutrient deficiency? And so, this could be for several reasons. It could be that there's inadequate intake. So perhaps your nutritional regimen hasn't been adjusted in a while, or it's just not enough calories or protein for your needs, and it's just inadequate. Or it could be that you're getting a lot of calories, but you're just not absorbing, or the body's not able to utilize those calories. It could be that there's potential shortages, and so you're not able to get the nutrition that you need. And I know several of you have been dealing with shortages with formula, and if anyone's on parenteral nutrition, definitely some of the components of parenteral nutrition. Or it could be that there's intolerance to a tube feeding regimen, or there's severe constipation or malabsorption, diarrhea, those kind of things that could contribute to some of these deficiencies, or perhaps malnutrition. So some of those losses can cause some of these findings. Additionally, medications can cause some of these deficiencies as well. And so just being mindful of those. And we'll walk through some of those together. We know that some medical conditions are more likely to cause deficiencies, or associated with some of these deficiencies. And so I just wanted to list those. I'm not going to read through this whole list, but really the point with these slides is just to take note that these conditions that have some malabsorption are going to be more likely to result in some of those fat-soluble vitamin deficiencies, which I'll show you some photographs of. Or there's just some conditions where you might see essential fatty acid deficiency from malabsorption. Or perhaps it's a condition where there's increased needs just because the body just needs more of a nutrient, or more calories, or protein, or fat, because of what's going on with the body. And an example of that would be, a patient, with burns, or someone who has some skin breakdown or wounds. There's going to be an increased need for some of these nutrients. So when we do this exam, and so when I say an exam, this is a little bit different than what your physician might do. It's a nutrition exam. And so, as a dietitian, when I would look at patients, I would look closely at their hair. And some of the things that I would take note of would be the color of the hair, has there been any changes in the texture, any hair loss. And then moving to the eyes, I'd want to take note of any vision changes, and we'll go through some deficiencies that might affect the vision. Any lesions on the white of the eye, what is the color of the lining of the eye? And then moving to the mouth, any cracks or fissures in the corners of the mouth, what is the color of the oral mucosa and the lips? We can learn some things by looking at the nails and the shape of the nails, the color of the nail bed, the texture of the nails, and then in looking at the skin, we're going to take note of the color, if there's any lesions or rashes. And so those are some of the things that I'm going to walk through throughout the remainder of the talk. I think it's really important to note that you can see some of these things and they might not be nutrition related. And so there are other causes, and an example of this, it could just be a stress of illness. And so if there is a bad infection, this can cause a condition that we refer to as telogen effluvium, which is like hair loss, but it's a result of stress on the body, and it's not necessarily nutrition related. It could be a medication side effect, and so maybe it's a medication that's causing hair loss, and it's not nutrition related. A hormonal change, an endocrine disorder, hygiene-related reasons for, let's say, like bleeding gums, might not be vitamin C, it might be the need to floss more. And so we just want to be careful that, just because you see a physical finding, it may be nutrition related, and so you want to work with your healthcare team to put it all together. But the purpose today is that if you do see one of these signs, is to say, I wonder, is this nutrition related, and just take it back to your team. So let's jump in here to some of these. And the first one that I'll talk about is vitamin B6 deficiency. And with this deficiency, you may see something called seborrheic dermatitis. This basically, if you look at the scalp, looks like cradle cap. And if you look at the eyebrows, you may see a waxy, scaly buildup in the eyebrows, or there's an area around the nose, and you may see a rash there with a waxy buildup there as well. And with vitamin B6 deficiency, this may be seen with some of the medications, with malnutrition, malabsorption, and so that's just something to be aware of. In looking at the hair and skin, so this was a consumer that I had seen in clinic who was on a very low-fat tube feeding for pancreatitis for a very long time. So she was placed on it in the hospital, and then we saw her for the first time in an outpatient setting, and so she presented with this dry, scaly rash, and it's called scaly dermatitis. And this is seen with essential fatty acid deficiency. So she had the flaking skin, and then she also had significant hair loss. And so her mom described that her hair was just coming out in clumps. And so we knew that day that she was not getting enough fat in the tube feeding. It was only 1% fat. And so we, I talked with her gastrointestinal team and just said, I'd like to, increase her. And so we put her on a peptide formula and then checked her pancreatic enzymes, and then we were able to transition her to a regular formula. And over time, as we corrected her deficiency, then the rash went away, and she ended up, I should put an after photo up here with a really thick little cute bob haircut. And so I think that makes the point that, with repletion, these signs, we should see them resolve. This next picture is a Beto spot. And I've seen these spots on the eyes in some consumers with malabsorption, specifically cystic fibrosis. And these consumers were having difficulty with taking their fat-soluble vitamin or their pancreatic enzymes. And so they presented with lesions on the white of the eye. And these lesions look kind of like a frothy, foamy lesion. And those consumers also had some night blindness. And night blindness is associated with vitamin A deficiency. And so the consumer was saying that she would trip over things in her house in the evening when it was a little bit dark, and had some trouble seeing, and wasn't able to drive at nighttime. And so with this, then we definitely referred her to ophthalmology as well. And I think that that's really important too. We have your team that's managing the nutrition, and they have access to all these specialists too. And so when we see some of these findings, especially anything with the eyes, we would also have ophthalmology look, just to make sure we weren't missing something. But after replacing vitamin A, these lesions then resolve, and so it's just something to take note of. I'm going to go back because I want to talk about the one on the bottom, because this is a pretty easy one to do, and this is looking at the lining of the eye. And it should be, when you pull down the eyelid, that lining should be pink, light pink in color, and not white and very pale. And so if you see that it's really pale in color, it could be an indication that there's anemia. And then you'd want to discuss that with your healthcare team so that they can evaluate for potential anemia. The next thing we'll talk about is some findings with the skin. And this first picture on the top is, it's called follicular hyperkeratosis, and that just means keratin coming out of those hair follicles. And you can see this with vitamin A deficiency or vitamin C deficiency. And you can also see this condition on the chest of patients, as well as on the legs and arms. And with vitamin A deficiency, you can see that in malabsorption, and vitamin C deficiency if there's malnutrition and malabsorption as well. The bottom picture is corkscrew hair, and that's where the hair is coming out of the hair follicle in the shape of kind of like a question mark. And it's just not coming out straight like you would expect. And it's known as a corkscrew hair, seen in vitamin C deficiency. This next slide is some pictures of findings with the mouth. And typically, those findings are B vitamin deficiencies. And when we talk about vitamin deficiencies, they often don't occur with just one. There could be several B vitamin deficiencies. And so that first picture of the infant is a pretty severe example of angular stomatitis. But the picture next to it is more often what I would see in clinical practice. And it's just like small fissures or tears in the corner of the mouth that are associated with some of those B vitamin deficiencies. You can also see these with iron deficiency anemia. That bottom picture is a picture of scurvy or a vitamin C deficiency. And this, you can see little hemorrhages on the tongue as well as bleeding gums. And I've seen vitamin C deficiency in a few patients, and I'll show you some other findings on the skin here in a little bit. Whenever there's a vitamin C deficiency, there's usually some bruising or bleeding that would occur with vitamin C deficiency or vitamin K deficiency. The next picture is magenta tongue, and this is just the color of the tongue, which would be purplish in nature, and this may be seen with B12 deficiency or some of the other deficiencies. Consumers who are at risk for B12 deficiency would be those that maybe you don't have the terminal ileum intact and may require some B12 injections in order to prevent deficiency. Also with B12, it may present as glossitis, which is where the tongue is inflamed or glossy. You're not able to see those taste buds on the tongue. And you can see that in iron deficiency as well as some of those B vitamin deficiencies. That's also a painful condition if the consumer is complaining of any kind of mouth pain, or it may be that there's one of these deficiencies going on. So this picture is a consumer that came into clinic, and he had really bad skin breakdown and had been followed in clinic by a wound team, and had some wound vacs at home, and was a patient that needed his tube feeding optimized as well, in attempting to kind of work on some, repleting his nutritional status. And that is his leg in that picture. And you can see that there's little hemorrhages at the hair follicle. It's called parafollicular hemorrhages. And so he actually, when we checked his vitamin C, it was non-detectable. And that day in clinic, because he had all those wounds and because of these physical findings, we didn't wait for the vitamin C level to come back to start him on vitamin C. We went ahead and started him on vitamin C. He also had some findings with the white of his eye was also hemorrhaging. It was very, very red. And his dad thought that he just had allergies. But it was, again, remember vitamin C, bruising and bleeding. It was actually a little bit of hemorrhaging in the eye. And then he also had some bleeding gums. And so classic vitamin C deficiency. When we optimized his tube feeding and replaced the vitamin C, these physical findings resolved, his nutritional status improved, and his wounds began to heal. Because you need vitamin C in order to make skin and make new skin. And so just, seeing that physical finding then was really important in being able to have an intervention. So if you see any of these things, in yourself or your family member, then take that back to the medical team for evaluation. Looking at the nails, sometimes there's findings that are nutritional related to the nails. And so the first one, it's called koilonychia, and that's known as spoon-shaped nails. And so the nail bed should be a nice downward curvature. And if it's curving up like a spoon, then it could be that there's an anemia or iron deficiency anemia. And so I had a little girl in clinic, and her mom said that she was dancing in her sleep. And so she had restless leg syndrome as well as these spoon-shaped nails. And so the literature talks about low ferritins being associated with restless leg syndrome. And so we checked some iron studies, replaced her iron, and then her nails improved, but also her sleep improved. And so that's just a little note there about iron deficiency replacement. That middle picture is splinter hemorrhages, and these are associated with vitamin C deficiency. And so just being aware of that finding would be important. White nail beds may be seen with selenium deficiency, and so that can be seen in patients that have malabsorption or patients on long-term parenteral nutrition. This picture is a consumer that had intestinal failure and high output ileostomy. And we saw her in clinic, and she was just getting a standard amount of zinc in her parenteral nutrition. And so she presented with this rash here around her mouth. But also, she had these blisters that I had never seen before. They're called vesicle bolus lesions, and those are associated with zinc deficiency. When we saw this, we started her on additional zinc in her parenteral nutrition with the next order. But also, we referred her to dermatology because, again, we wanted to be sure we weren't missing something else that's going on. Because remember, some of these findings can have some other causes. And so they confirmed that it was zinc deficiency. And then she improved as well with additional zinc supplementation. Other things that you can look for in the skin would be the color of the skin. And so something called pallor, which is pale skin, may be an indication of an anemia. And then palmar pallor, where you just look at the palms of the hand. If they're really pale in color, that may indicate an anemia as well. So I'm going to move now to the malnutrition portion. And this is where some of these pictures are examples of severe malnutrition. And the purpose of that is so that you can see some of the landmarks that we look for when we're looking for where there's muscle and fat wasting. But again, these are some pictures that may be a bit triggering, so feel free if you need to step away to do so. So when we are assessing for malnutrition, we look for fat loss, muscle wasting, and also changes in functional status. So I'll walk through some of those. One of the first places that we see changes in malnutrition is the face, and so taking note of fat loss that may be around the eyes, and if there's fat loss there in that orbital area, which is the eye socket, then that may be an indication of some early undernutrition. With this finding, though, you can also see sunken eyes and those dark circles with dehydration. And so it may not be that it's undernutrition, but rather just the need for additional fluid. And the next area to look for would be around the cheekbones. And so sunken cheekbones may be an indication that there's some fat wasting, or it may just be the person's bone structure as well. And so just taking note if there's been weight loss, but also some orbital fat loss or buccal fat loss, that may be an indication of some undernutrition. Looking at the ribs and looking at if you can see distinct ribs in the front or the back, that may be an area of fat wasting. And then we look at the triceps, and even though the tricep is a muscle, that's an area we assess for fat. And I don't know if you've seen the skin calipers for tricep skin folds. We will use our fingers sometimes in clinical practice and just separate the muscle, the tricep muscle, from the fat. And there should be some ample fat there between the two fingers. And if I take that fold there and my fingers touch, that may be an indication that there's some fat wasting. And so that might be helpful to look at. So that would be what we assess for fat loss. In terms of muscle loss, again, one of the first places that we would see muscle wasting would be in the face. And there's a muscle on the side of the head called the temporalis muscle. And you can feel it if you put your fingers on the side of your head and kind of chew. And you should be able to feel that muscle moving up and down. And if there's wasting there, maybe the fingers will go into a little indentation there. And so that's something to note as well. And then moving down, we would assess the chest muscles and the pectoralis muscle. The landmark that I look for there is the clavicle. And in women, we have more prominent clavicles often, and so that might not be a sign of undernutrition or malnutrition. But if you can hook your finger up under that clavicle muscle, that may be an indication that there's chest muscle wasting. And then you can see the picture there of the shoulders. If the shoulders are really boxy in nature, there should be a curvature if the deltoid or shoulder muscle is intact, and so it may be that there's some wasting if you can see prominent shoulder bones there. The next thing to look at would be the quadriceps, and so the quadriceps, there's 4 muscles in the quadricep. And if there's wasting there in the quadricep, you may see some lines where there's been some wasting there, where it'll look just like kind of like a strip of muscle sitting on top of the leg, and the other muscles may show some wasting. When the wasting is down to the lower extremities or the legs, that's where we may see that it's affecting functional status, which we'll talk about in a moment. Also looking at the muscles in the back is important, and so there's a wing-shaped bone back there called the scapula, and if that's really prominent, it may be that there's some wasting in those muscles that are in the back. And then the calf muscle, that should be, that's in the bottom of the leg in the back, and that should be a really firm, kind of bulbous muscle, and if it's really flat and soft instead of firm, that may indicate that there's some muscle wasting in the lower extremities. So we look for fat wasting and muscle loss when we're assessing some changes in nutritional status. And then when the muscle is affected, oftentimes that's where we see changes in functional status. And so what is functional status? That is different for everyone. So we always just want to get an idea of what the baseline is. And so when we talk about activities of daily living, we want to know if there's any changes in that. Are you having trouble going up the stairs or doing the laundry or cooking? Or for children, it would be, are they playing less, sleeping more, not able to go to therapies, things like that. So changes in functional status that are accompanying weight loss may be an indication of undernutrition or malnutrition. So when we talk about these findings, what are some next steps? You definitely want to notify your team and talk, set up an appointment or talk with them. Now, what I learned during COVID is that we learned we can do some of these things virtually. And so we would often be able to have visits. And so that, I don't know if that's something that your teams do, but it might be something that they could take a look at virtually, or they may want to see you in their office. Taking pictures is always helpful in case the finding changes, and so that's really helpful to share photos. I know we looked at a lot of photos during COVID that were sent in to us, and we could actually use those photos. We would adjust tube feeding and then monitor with photos that the families would send, and we could see repletion over time. And so photos are very helpful. Bringing a record of input and output records, and so of, if there's an increase in the number of bowel movements or ostomy output, or that would be very helpful for your team to know when they're looking at some of these findings and whether it could be associated with malabsorption. Perhaps there's something medically that they would change with the plan, or nutritionally. And then just bringing all of your supplements with you to your visit. And that's really important, so that the team can look at, what is the supplement, what is the amount, and this includes all supplements, vitamin, minerals, herbs, anything that you're taking, so that your team can kind of put it all together. Because sometimes, if you supplement one thing, it can cause a deficiency in another thing. And so an example of that would be, maybe there was a zinc deficiency because of really high output. So your team started you on zinc, but then you stayed on it for a very long time, and that ended up causing a copper deficiency or an iron deficiency. And so really important just to bring all of your supplements to your team so that they can do an evaluation. And then if you are started on a supplement for a deficiency, just being sure that you take the entire course and that you follow up, so that the team can see and that you can see that it was effective. Because it could be that maybe they thought you needed a certain amount, but you actually needed more because of absorption, or because of how you were how your body was handling the supplement. So really important to follow up with your team. I know in practice sometimes we would start patients on supplements and then wouldn't see them, and either the deficiency didn't resolve, or like I said, they sat too long on zinc, and we wanted them to not take it as long as they did, and so really just very important to follow up with any of these deficiencies. So interventions, just working with the healthcare team, making sure that your nutritional regimen is appropriate, and that it's meeting all of the macronutrients, so the big nutrients, as well as the micronutrients, because those little vitamins and minerals do a lot in the body. That at the cellular level, we call them cofactors, and so there are things that we need to ensure that are there for the body to do what it needs to do. And so working closely with your team just to make sure, with tube feeding regimens, your team or your dietitian, if you have a dietitian, can do an analysis of the tube feeding to be sure that it's meeting the daily requirements. And we would routinely do that with our patients, and especially sometimes the needs would be very low depending on metabolism. And if it's a really low calorie tube feeding, then you're going to be at higher risk for some of these nutrient deficiencies. And so And then it could be that, a lot of times when we think we're meeting the needs of the consumer because there's a certain volume, and we say, well, if they're getting at least a liter, then we should be meeting the needs. That's not necessarily true. It's very individualized, especially in conditions with malabsorption or if there's increased needs. And so have your team, ask them, hey, have you looked at my tube feeding regimen, and is it meeting all of my needs, not just my calorie and protein needs, but my vitamin and mineral needs? And there's programs where they can do that really quickly. Plug in the tube feeding and the amount, and it'll show if they're meeting the needs. So that's one thing that may be helpful. And then working closely and communicating with your team in times of shortages, and I know that many of you have had to deal with those, and so just staying in close contact with your team during those times. If there's any changes, intolerance, working closely with your team to correct the root problem, because I know that affects the ability to get in your nutrition for that day if you're not tolerating it or not able to get your total volume in. So that's something your team would want to know, because perhaps they would consider changing your product or changing the volume or the regimen. And the last thing is, just being sure that your quality of life in terms of the schedule for your for the nutritional regimen is working for you. Because a lot of times, I worked in both the inpatient setting and outpatient, and patients, consumers, would go home on regimens that worked really well for the nursing staff, where there's 24/7 care. But then, they get home, and if a tube feeding is running over an hour, every 3 hours, then that's a very long time and not very manageable for home. And so we just want to be sure that it works for you. But I'm going to wrap it up here and allow some time for questions. So thank you. And if there are any questions.
I'm on enteral feeding, Jevely 1.2 since September. I take 8-ounce cartons a day as my sole food of nutrition. Am I missing anything, like any kind of something? Should I take a multivitamin once in a while or anything else to supplement that Jevely, what it provides?
Yeah, I would definitely talk with your healthcare team, because I'm not sure what, your absorption is or anything like that. That's a perfect example of, just it sounds like the volume is appropriate and should meet the needs, but I would always ask your team, is this enough? Is this enough for me to meet my needs according to whether I'm, how absorption is or other factors medically that may be going on with you. But yeah, I would definitely take your regimen back to your team and ask those questions. I think it's really great, and I loved it when patients were really proactive in evaluating the regimen. And again, we have things we can do pretty quickly to take a quick look at that. Any other questions?
Yeah, is there a concern of where the tube is placed? So if you're getting jejunal feeds, is there vitamins or minerals that aren't being absorbed because the feeds are going into the jejunum?
Yeah, definitely. Anatomy is really important when we're talking about absorption. And so it may be that you may need additional nutrients depending on absorption. And so there's going to be a higher risk the lower your tube is down at the bowel, because some of those things are metabolized or are absorbed in the duodenum, and so we want to be sure to have those things evaluated then with your team. But definitely a really good point that tube placement and anatomy is really important when we're talking about absorption and evaluating these deficiencies. Any other questions?
How do you find a dietitian if it's not part of your regular healthcare team?
How do you find a dietitian?
Yeah.
Yeah. You could, the Academy of Nutrition and Dietetics has a website that may be a helpful place. I think I heard something about a database of providers. I'm not sure if dietitians are part of that. Maisie's shaking her head that they are, so that'll be great. I would ask your team too, if because they could pull someone in from your healthcare system, depending on who that is. Sometimes it's just a matter of asking to be connected with a dietitian to help them guide your nutritional care. But the Academy of Nutrition and Dietetics. But it sounds like what was the name of that, Maisie?
The healthcare directory.
The healthcare directory.
Yes.
So it sounds like watch for that, and they're in the process of populating that, and dietitians will be part of that. But I mean, I'm biased, of course, because I'm a dietitian, but I love working on in a multidisciplinary way with physicians and other specialists, because we can all help each other be sure that we're meeting your needs the best way possible. So I want to thank you for your time. We're at time today, but thank you for allowing me to participate in the conference, and I've enjoyed really talking with many of you throughout the conference. Thank you.
Don gave me this one, so I'm going to use this one. Thank you so much, Jody, for that presentation. Next, we will be hearing from Carolyn Crumley. Not going to stand by that. To speak about hair and keeping it intact. I'm going to give this back to Dawn. I can't be trusted.
Welcome. I don't know if we need a couple minutes if you feel like you need to stretch or, move around a little bit. I know it's hard sitting still for a long period of time, so feel free to move around a little bit or anything if you need to. And again, my name is Carolyn Crumley, and I'm going to talk a little bit about skin. Show me how to keep it intact. So I welcome everyone to the Missouri Show Me State. If you didn't know that, we are called the Show Me State, so that means you can't just tell us stuff, you have to show us. So I'm hoping to show you a little bit about how we manage keep the skin intact and then manage skin conditions. And I currently live in Kansas City, but I actually am from St. Louis. I grew up here and have family here. So hopefully you'll enjoy our city and have a chance to, if you are able to eat some Emo's Pizza and some Ted Drew's frozen custard while you're here. So I have no financial disclosures. I have the learning objectives there. We'll talk a little bit just about the what the skin looks like and how it functions, what some of the issues are related to skin, and then hopefully how to resolve some of those. And I think we'll get through this fairly quickly, so I should have time at the end for any questions. And then I believe also there's a round table or some kind of a session over in the exhibit hall where some of the speakers are available if you have individual questions, so I'll be in there also. So I work at St. Luke's East Hospital in Lee Summit, which is a suburb of Kansas City. And of course, Kansas City is known for Go Chiefs, Super Bowl champs. And then I also am an adjunct faculty at the University of Missouri-Columbia, and I am a section editor for our journal, the Journal of Wound Ostomy and Continence Nursing. And both individually and on the local level and the national level, I am very involved with the Wound Ostomy and Continence Nurses Society, which is more of a professional organization for providers. But then we also work closely with a couple of the patient advocacy groups that are associated with our practice, including the United Ostomy Association of America, who works with patients with ostomies, and also the Friends of Ostomates Worldwide, which is an organization which collects ostomy supplies that are no longer needed by the patient. Maybe they changed the type of pouch they're using, or they've had their ostomy reversed, and they collect those and send those to third world countries where they really don't have access to supplies. So we support them with donations of financial donations, and also with sending them supplies to help out those patients. So a little bit about the skin. You can see kind of a depiction there. Of course, we can't really see this on a visual level because the skin is really very, very super thin. And it varies a little bit. It's the thinnest in your eyelids. It's a little bit thicker on like the palms of your hand and the soles of your feet, but still it's very, very thin. Not anything that we're going to be able to see these features except with a microscope. And so, let me move over here a little bit so I can see this one a little bit better. So you do have the hypodermis, which is the inner layer, which is where you have all of your blood supplies, so your arteries and veins. It's also where you store your adipose tissue or your fat tissue. Some of us have more of that than others in various parts of the body, but that does serve a purpose. And then in the dermis, where you still have blood supply to that, is where you have some of the skin appendages. And so this would be like the hair follicles and the sweat glands and the sebaceous glands, which we'll talk about a little bit more as we talk about some of the skin issues. And then the outer layer is the epidermis. And so it has several little layers, again, if you looked under a microscope. And what happens is the bottom layers of the epidermis make new skin cells on a regular basis. So about every 14 days or so, those skin cells that are formed at the surface kind of migrate up, and then as they migrate up the levels, the nucleus dies and they sort of die off, and then they flake off. Now, this is all microscopic, so it's not really anything that we see. We don't see the skin coming off. Most of it is when you're either like showering or bathing or even putting on clothes where you kind of brush some of it off. But if you go around your house and dust with your little swipper or your dust rag and you see all that dust, a majority of that is skin cells that we just don't see. And that becomes important because sometimes that natural process gets interrupted and we see skin problems with a patient who maybe has had a dressing for a long time, or just that area is not getting cleansed, or there's not anything to brush the skin off, so it can build up a little bit and create a problem. So the skin is, although it's the largest organ in the body, a lot of times we feel like, it gets pushed aside from all of the other organ systems, which naturally, cardiac and pulmonary things come first, GI things, but a lot of times the skin is an afterthought until we start having problems with it. And I think a lot of people don't really understand what the various functions of the skin are and why it's so important to keep it functioning properly and keeping it intact. So one of the things that it does is thermoregulation. So it regulates our internal body temperature. First of all, like I mentioned, we have those fat cells that are in the hypodermis that provide really good insulation to the insides of our body. But then also the blood vessels in the skin can either vasodilate, meaning expand, or constrict, meaning narrowing down, to help your body get rid of extra heat or conserve that heat if you need it. So it really serves an important function throughout the body. Again, with that insulation goes along with it. As far as immunity, of course, we know that intact skin is a barrier to any kind of organisms entering the skin. And even when you can have like a small little cut, we've seen people even with like a little paper cut on their finger, that if you get the right bacteria in the right circumstances, that can set up an infection because now the bacteria has found a way to get into the skin. But even aside from that, the skin also produces various substances that help our immune system to fight off infection. Sensory perception, of course, is where we get our sense of temperature and pain and touch, and also itching. We kind of talked about the barrier protection. Along with that, too, our skin, and this will be important because we'll talk about this in a few minutes. Our skin, the natural pH of our skin is on the acid side. So if you remember from your science classes in high school, there's pH, and 7 is like right in the middle where it's not acid and it's not base or alkaline. And so our skin tends to be a little bit on the acid side. So it has a little bit lower pH, like anywhere from 4 to 6.5. So a little bit less than neutral. And that's important because that also plays an important function in, again, maintaining all of these activities of the skin and reducing the risk of bacteria creating a problem. And then lastly, the skin serves a purpose as far as vitamin D synthesis. So we know that you need to get a little bit of sunlight. That's what helps your body synthesize vitamin D. Takes a combination of some sunlight and in the skin, that's what we use to come up with the vitamin D that we need for our functioning. And if you have low levels of vitamin D, you can have issues. Of course, what we normally think about is like bone loss, because if you're low in vitamin D, you don't maintain your bone integrity as well. But they're also finding more that it does have a role in our immune system and keeping it functioning, and also actually even preventing some types of cancer. So again, that's where the skin plays an important role. Okay. So it helps to have that little bit of a foundation about how the skin works in order to talk about some of the ways that we can just normally keep it intact, and then also address some of those issues that we sometimes see where the skin is not intact. So it is important, again, because of that acid mantle, that we want to use products that are pH balanced. And of course, we see that on a lot of advertisements. You know, this is pH balanced on soaps and shampoos and lotions and creams and everything, but we'll talk a little bit more about what that means. We also want to make sure that you're avoiding really hot water or overly cleansing, because that can also affect the skin integrity. Especially as we get older, as we're younger, we kind of get used to taking a bath or a shower every day. But as you get older, you really a lot of times don't need to bathe completely that frequently. Some people do every other day, or especially like a lot of individuals that are in nursing homes, they only bathe them a couple times a week. They may kind of wash their face and do some peri-care, private areas, but you don't need a full bath and shower, because a lot of times then you're just drying out the skin, and again, that can lead to some issues. And then it is important, it's kind of just common sense and I think practice, but it is important if you are going to use any moisturizers, it's really best to put those on right after you bathe, right after you get out of the shower or bath, because it helps trap that moisture a little bit more and keeps the skin intact. So there are, tons and tons of skincare products on the market. We have certain ones that we use in the hospital because I do work primarily in the hospital and seeing patients, so we have what we have on formulary. But if you go into, your local discount store or drugstore, you can find a million different skincare products. And it's really hard. People always ask me, well, what's the best one? Well, I think everybody sort of has their favorites. But you do need to understand what the ingredients are, and sometimes when you understand that, you can look a little bit more closely at the ingredient label and see what's in there, and what are the more active ingredients in there. So most of the different skincare products are broken down into humectants or emollients. So humectants actually actively attract water into the skin. And so that's things like urea, lactic acid, glycerin, and the alpha hydroxy acids. Most of those are over the counter. There are a few of those, especially containing the urea, that are prescription, that may need to be prescribed by your primary care provider or by a dermatologist. Lachydrin is one of those that we use in the hospital that has like a 12% urea, but it does require a prescription. So those help really pull that fluid into your skin. The emollients are more for like softening and moisturizing and sort of keeping, once you have that moisture in the skin, keeping the moisture in. And some of the main ingredients of that are going to be silicone, dimethicone, lanolin, and then one of the newer ingredients is the ceramides. That's kind of a hot topic both in the cosmetic skincare industry and then also within healthcare. We now use some products that have ceramides because they know that that can help maintain the normal skin integrity. So the common one on the market is CeraVe. They have a lot of different ones that have ceramides in it. So again, as we talked about earlier, as far as the pH of soaps, now this is not something that you're going to see regularly if you pick up a bar of soap or a bottle of some kind of a liquid cleanser. They don't generally say on there what the pH is. Again, there's really no guidelines for them calling it pH balance. They can kind of put that on there regardless. But there are several websites that you can go to. This was a particular one that I found. If you Google it, you can find, if you just Google pH of soaps, you can find all these. And this was just a partial list. It was from this particular website that I had found that listed several of the common skin cleansers. And they go in order of the lower pH. And as you can see, some of them, you know, that we use pretty regularly, like Zest soap has a pH of 10. So again, if we want to keep it on that 7 or under, you know, we want to try to avoid those ones that have the higher pH. Even Johnson's baby soap, which is supposed to be good for babies, but it's got a really high pH. So if you're curious about what you normally use or want to try to get into something that has a lower pH, again, there are multiple websites that will list the pH for you. Okay. So that's kind of just an overview of normal skin and how we maintain it under normal circumstances. And so now I'm going to talk a little bit about some of the issues related to individuals that do have various ostomies that it could, and we see common problems around the skin, and then we'll talk a little bit about what some of those problems are and how they can be dealt with. So again, I'm a wound, ostomy, and continence nurse. So as the name implies, we deal with patients with wounds, with various ostomies, and with continence, bowel and bladder control issues. But our specialty originated as ostomy nurses. So we used to be, years ago, when I'm old enough that even back when I went through the education and the certification, we were called enterostomal therapists. So you sometimes still hear us referred to as ETs. And in some other parts of the world, they're still called ETs. And so we work a lot with patients who have had either a colostomy, ileostomy, or a urostomy. So we'll talk a little bit about those. A colostomy or an ileostomy is a diversion in their GI tract involving stool. Urostomy, I really didn't talk about too much because it's less common, although some of the principles would apply. Those are a patient who's had their bladder removed, and so their urine drains through an opening on their abdomen. So our specialty really probably deals with those more, but through the years we have also sort of picked up what we call other tubes and devices, like gastrostomy tubes and jejunostomy tubes that may be used, especially initially in the hospital. Sometimes gastrostomy tubes are actually used to decompress the GI tract or to pull fluid out, but then eventually used for feeding. So we'll talk about those a little bit. Just in general, and then some of the skin conditions involved. So here's just a picture of your GI tract. I'm sure you are all very familiar, but this is where we start with our new ostomy patients, just explaining a little bit about how the GI tract works, because then it starts making more sense to them in relation to the type of ostomy that they have. So as you're familiar, if you are taking orally, you ingest the food, it goes into your stomach. There it starts to mix with some digestive enzymes, and some of the acid in the stomach starts to break down some of the nutrients. Especially it's important for breaking down the vitamin B12. There's also some intrinsic factor that's released in the stomach that has to do with B12 absorption. Talked about a little bit in the previous session. So the food kind of starts to break down, mix with some of those digestive enzymes, and then it goes all through the small intestine, which is sort of all over the middle of your belly. It's the longest part of the intestine, and that's where you absorb most of your nutrients. So your proteins, fats, carbohydrates, vitamins, minerals, most medications. There's a few that are absorbed in the stomach, but most medications get absorbed in the small intestine. It's still pretty watery at that point, and that's important for patients that have one of these ostomies as far as the consistency of their stool. Then from the small intestine, it enters the colon or the large intestine on the right-hand side, which is a little more fixed, comes up the right-hand side, goes across through the top of your belly, down the left-hand side, down to the rectum and anus. So the main function of the colon is to absorb water. So the more, when it starts out in the colon, it's pretty watery. The farther along it goes in the colon, the more water gets absorbed. So then you have the formed stool, and your rectum and anus give you the voluntary control. Then we'll talk a little bit about some of the different ostomies and what that means in relation to what it means for their digestive system. Because again, they get all kinds of weird misconceptions about, what's going on with their, that they can't eat certain things, or they're going to have to, do all kinds of different things that are misconceptions. So we also, along with that too, some patients, again, have a gastrostomy tube, or it's sometimes called for short a G-tube, or a PEG, which is a percutaneous endoscopic gastrostomy. And these are tubes that are inserted into the stomach. And again, they may initially be to drain, to decompress the stomach, but then often used for feeding. Again, we don't, as WOC nurses, we don't get very involved with the nutritional aspects of it because we deal with our dietitians and our nutrition teams or our GI doctors as far as prescribing the type of nutrition that goes through the tube. But where we get called a lot is because then the patient has developed some irritation around the tube. And I have a few pictures. I don't have as many for the gastrostomy tubes because we don't see them as much. But a lot of times when we do get consulted, invariably it's because they have an infection or cellulitis because there's some redness around the tube. And in reality, what it is more, and we'll talk about some of the moisture-associated skin damage, but really in reality, it's more that something is leaking around the tube, most often because it hasn't been stabilized well. And if the tube is not stabilized, the more it wiggles around, the more it makes the hole bigger, and the more things tend to leak around it. So a lot of it is just stabilizing the tube and minimizing the leakage, and then some of the basic principles as far as managing the skin irritation. Very rarely do we actually see true infections or true cellulitis. It's possible, but most of the time, whoever put in the consult just saw that it was red and assumed that it's infected. Jejunostomy tubes then would be farther down into the small intestine, for some reason maybe needed to bypass the stomach because of issues. So these would be generally feeding tubes that are inserted into the jejunal part of the small intestine. We don't tend to see quite as much leakage with these. They're a little bit smaller tubes, and at least in my practice, we don't see them as much in the hospital. But same principle, we can sometimes see some of the issues with irritation around the tubes. Far more often we see issues with our ostomy patients. So a patient who has had a colostomy could have a diversion anywhere along their colon. So it could be on the right side, the ascending colon, anywhere in the transverse colon up across the top. Generally, they try to do them in the descending or the sigmoid colon. So the farther down, so we've not bypassed as much of the colon. So really, those patients, if it's a low descending or sigmoid colostomy, it really hasn't affected their ability to their nutrition or their ability to absorb nutrients at all. Really, the only thing they've lost is that voluntary control of the rectum to expel the stool. So these patients tend to do a lot better, both from that standpoint, because it hasn't affected their nutrition and absorption, and also the stool is more formed because it has had a chance to go through the colon. So formed stool coming out, even if it leaks on the skin, is not as irritating. We try to explain it's just like if you have a baby and they go around, they'll walk around all day with a diaper on with formed stool in it and not have any issue. But then when they have diarrhea, then that's when they get like the diaper rash or the diaper dermatitis. So these patients tend to do a little bit better and not have quite as many issues. Patients that need to have an ileostomy, again, now we've basically bypassed the colon. The food is not going through the colon, so they have sometimes some more issues with nutritional deficiencies, with dehydration, with not absorbing as well. Also, the stool is a little bit more loose, so there tends to be more issues with it leaking or causing issues on the skin, can be a little bit more problematic to manage. And then patients who have these ostomies use various types of devices. There's literally hundreds of them on the market. I've seen lots of changes since I started in this, 40-something years ago. A lot of the products now are really much more skin-friendly and easy to use. And again, there's various companies that make all kinds of variations, but they're usually a variation of one type or the other. So it's either a one-piece pouch where you have the skin barrier and the pouch connected, so it's just everything goes on together, comes off together. The barrier is cut to the size of the ostomy, and then it adheres to the skin. So they're all adhesive. There are a few non-adhesive options for patients who really have issues with their skin or with the adhesives. Most people prefer to use the two-piece, and there's a lot of different two-piece, so that's where the barrier adheres to the skin, and then the pouch either snaps on by some kind of a device, kind of like a Tupperware seal, or some of them are adhesive, where it's just adhesives that connect the pouch and the barrier together. And that's part of what we do then, is teaching the patients how to manage it, helping them problem solve if they have special needs for their ostomy. Okay, so now, again, if everything works perfectly, these patients have these G-tubes or J-tubes or ostomies and not have any issues, but unfortunately we do see a lot of different issues associated with it, and they fall into the category, the general category that was developed over the term that's kind of come into place over probably the last 10 years of moisture-associated skin damage, or we call it MASD. So there's basically 4 forms of MASD. There's incontinence-associated dermatitis. So that's somebody who either has bowel or bladder incontinence and have some issues on their perineal skin or their buttock skin because of that moisture. Intertriginous dermatitis, which really can happen in any population, is more with the skin fold. So people have a skin fold somewhere and the moisture gets trapped, and we'll talk about that a little bit. And then there's peri-wound moisture-associated skin damage from some sort of drainage from the wound, moisture from any source. And then peristomal moisture-associated skin damage, which generally we think of more with the ileostomies and colostomies, but really could also apply to the gastrostomies and jejunostomies if they're having any kind of skin issues. So what happens with this, again, you have moisture from some source. It could be either perspiration that gets trapped, it could be urine, stool, saliva, wound drainage, leakage around a tube, whatever is causing the extra fluid to be contained. You get increased skin permeability, so that moisture, skin doesn't like being, it needs to be a little bit moist, but it doesn't like to be that moist. So then there's kind of increased permeability, and then that's where the pathogens can get in. So you can have more of the bacteria and the harmful components getting into the skin. And then also the skin is much more at risk for the dangers from friction or shearing or pressure. So again, somebody that has incontinence-associated dermatitis, where they have a lot of moisture, it's going to put them at a greater risk of having a coccyx or a tailbone pressure injury, because that moisture just makes them that much more at risk. So we want to try to do what we can to try to address that excessive moisture. So here's some pictures of some moisture-associated skin damage. Over on the far right, that's a fairly mild case that we see around a perianal area from some irritation. The upper one in the middle is pretty extensive moisture-associated skin damage. A lot of times people will think that's like a pressure injury or something else going on, but it's really just the effects of prolonged moisture. You can sometimes see it around a tube, I'm not sure if that's a G-tube or a J-tube on the bottom in the middle. And then this one on the far left actually was just a patient that I saw a few weeks ago. We got called down to the ER, and he was actually sent home with a drain. He'd had some laparoscopic surgery and had a drainage tube that sometimes patients will have after surgery to pull the excess fluid out. And he was sent home with it with a kind of an occlusive dressing on, so like some gauze and some Tegaderm over it. Tegaderm was like that clear adhesive. And he had been home for about a week, and it had started leaking a little bit around the tube, and nobody had instructed him to change the dressing, and it, I guess, didn't occur to him. So all that moisture was just leaking around there. You can kind of see the gauze that's folded back. So again, we got consulted for cellulitis, which means a bacterial infection of the skin. It's like there's no infection here. It's just from all that moisture being trapped on his skin. So as soon as I took that dressing off and cleaned it off really well and put a moisture barrier on there and then put a dressing back on, I mean, it healed up very quickly, which then makes us look really good, but it was a pretty simple fix. It's like, let's just get the moisture off. Now, this probably doesn't mean a whole lot to you as far as ICD-10 coding for moisture-associated skin damage, but this is something that our organization, Wound Ostomy and Continence Nurses Society, has lobbied for many years to have these codes recognized, and developing the specific codes for moisture-associated skin damage that they put under the category of irritant contact dermatitis, as opposed to like allergic dermatitis or radiation dermatitis. And the reason this is so important is that healthcare providers live and die by ICD-10 codes, because if there's not a code for it, you can't bill for it. So then it's hard to get people to want to take care of these patients because they really can't hardly bill anything for it. So this was really important in advancing the care of patients that have these type of issues, so that providers are more willing to see these patients, work with these patients, because they can get reimbursed. So it was a really big step that we've spent many years accomplishing. So that was a big accomplishment. Okay. So prevention and treatment of moisture-associated skin damage. The obvious answer is just try to avoid the excessive drainage. So again, if it's a tube that the opening has gotten enlarged, then try to stabilize it so it doesn't leak around it. Rare cases, sometimes they have to move the tube to somewhere else, but most of the time we can get it stabilized and get that under control. If it's an ostomy, then we need to make sure that we have a pouching system that is not leaking as much, and try to find some way to manage that. Or if it's really liquid stool, sometimes we work on trying to thicken up the stool, because if it's thicker, it's less likely to leak. If it's incontinence, then we want to work with them. There are a lot of ways that you can improve continence. Unfortunately, a lot of people think that as you get older, it's just a normal part of aging, and you just have to accept it, but there are a whole lot of different treatments, pharmacologic, non-pharmacologic, behavioral, that can improve bladder and bowel control. But again, a lot of times people don't seek help, and that is part of our specialty too, is working to do that. If we can't improve their incontinence, then ways to manage the moisture. If they're incontinent, maybe like for a man, an external catheter or a condom catheter to a bedside drainage bag. We want to try to avoid any of the catheters or internal devices because of the risk of infection, but there are a lot of different external containment devices. Or if they are going to have to use a containment product, something that really wicks the moisture away better, like the new baby diaper technology that wicks it away. Sometimes in like facilities or even patients buying their own, they buy kind of the cheaper products, and it doesn't have that really good technology that helps keep it dry. So that's the first thing we want to do, is try to figure out how can we contain the drainage. And then we want to protect the skin. So there's a lot of different options for that. And first of all, we want to make sure that we cleanse the skin well. Sometimes it's better to not use a lot of harsh soaps, and particularly with our ostomy patients, we teach them to not use a lot of soaps and lotions and creams, because that interferes with that adhesive barrier sticking, but also it can irritate the skin. And whether it's around a tube also, a lot of times people want to use a lot of really harsh cleansers that just irritates it more. And people love peroxide, right? Everybody loves peroxide. Don't you need to clean it with some peroxide? Well, peroxide has a lot of, is really harmful to healthy skin. And people think that it has antibacterial properties. It really has none. You know, it fizzes and it bubbles and it makes you feel like you're getting it clean. It is good if you have like a lot of like dried blood, like somebody who's cut their head and they got a lot of dried blood in their hair or dried drainage or blood. It kind of loosens that up. But it really doesn't have any antibacterial properties, and it actually destroys good cells. So we want to just cleanse with regular plain water, maybe a mild soap, and rinse it off well. We have different options and we kind of go in order. Sometimes you just need like a dimethicone based. Some of those are just more of the lotiony type materials that have some dimethicone that provides some protection. If you just need a little bit, sometimes that's enough. Then the next step, I should have kind of put these more in order, but the next step would be like a petrolatum or a Vaseline based that provides some moisture barrier protection. And then if that doesn't work, then we go up to the zinc-based, familiar with Desitin, what we use for baby bottoms. There's a lot more. I mean, years ago when my kids were little, all there was Desitin. Now there's butt paste and some kind of goo and all kinds of different things that they have. But it's basically all Desitin, zinc-based options. The only problem with the zinc-based is it's pretty thick, so it's sometimes kind of hard to remove. The key with it, if you really have bad breakdown, is to put it on thick, whether it's on a bottom, you know, an adult bottom, a baby bottom, a rounded tube. Clean it off good, put it on very thick, and then you don't necessarily have to, each time you wipe it all the way down to skin. You can kind of wipe off the outer layer, wipe off the urine or stool, and then put more on. And then maybe once a day or every other day, clean it all the way down to the skin. But we get patients that get raw from people trying to scrub the zinc-based products off. And then there are some liquid acrylates, which is kind of a newer category. They're like the skin preps. They sometimes come in like the little pledgets, but you can also get wands, and there's some really advanced ones on the market now that provide almost like a protective coating that sometimes last even up to 72 hours to protect the skin. So we'll just kind of go through these pretty quickly because I know we're running short on time. So intertrigo, again, is that what we talked about where you get the moisture trapped in the skin folds. We most often think of it in like the if somebody has a large belly and kind of under their belly and in their groin folds. We can also get it under breast, in axilla. And the main thing is just keeping it clean and dry and trying to wick away the moisture. So here's some examples of that. It's usually, we kind of call it a kissing lesion, where you see the same thing on either side in the skin fold. Usually the deepest damage is in the depth of the skin fold where the moisture is trapped. And the main thing is just keeping it clean and dry, keeping the skin separated. Years ago, in the hospital, all we had was pillowcases. When I did home health, we'd teach patients to cut up cotton t-shirts and put it in there. Now we have several commercially available products. And I guess I'm allowed to say brand names. Interdry AG is one of the brands that we use, that it's a special fabric. It's like the wicking fabric in athletic wear, like the dry fit moisture wicking, and then also has silver in it. So it wicks the moisture out to the edge and lets it evaporate so you don't have all the moisture in the skin fold. But it's good, like I say, sometimes even like around tubes, if we really want to wick the moisture away, we use it pretty creatively. Sometimes along with that excessive moisture, you can get fungal infections or candidiasis, which is like a yeast infection. The main way you can tell that is you see the little, what we call satellite lesions. So the little polka dots around the outside, which means that there's a fungal infection there. And so you do want to treat with that with some sort of an antifungal. There are ones over the counter. Miconazole powders and creams are available over the counter. Nystatin does require a prescription. There are some that also include steroids, which is kind of comforting and helps with some of the inflammation, but you do have to be really careful with not using that on a long-term basis because it can kind of thin the skin. You can also get folliculitis, which is an inflammation of the hair follicles. In the previous section, she kind of talked about some issues with the hair follicles, but this is actually where the hair follicles get inflamed, and it's usually either from shaving and then the hair growing back in, or something irritating it. So the best thing with that is to trim the hair rather than shaving it. If it's possible to not use adhesive devices, or if you do, remove them carefully so you're not irritating it. Sometimes they do need some topical or systemic antibiotics to treat that. And I'll just go through this quickly. Another term is medical adhesive related skin injury, which is MARSI, where you can have problems with the skin strictly because of the adhesive. And it can be in a lot of different forms. Sometimes we can see it around a tube. If you see in that upper right, it's where somebody had kind of ripped the skin, taking off an adhesive pouch barrier. And then sometimes you see like the skin tears like that below, where it actually pulls back a flap of skin from the adhesive. So the main thing with that is, again, if it's possible to not use an adhesive option, gently remove it. When you do put it on, allowing it to dry really well, and then avoid using tincture of benzoin. A lot of people use that because it makes stuff stick, but sometimes it makes it stick too much. And then lastly, we don't really deal a whole lot with patients with central venous catheters, like for parenteral nutrition, but occasionally we do get called to see them because they have some redness. And typically what it is it's because when they did the care around the site, they didn't allow it to dry well and put the adhesive on it to trap moisture. But this was a recent study that was just in our journal last month, looking at some patients who had a central venous catheter. Now, these were more patients for cancer treatment, but they looked at a total of 1,172 patients, found that some of the risk factors for having issues were because they had a previous MARSI injury, they were on TPN, other catheter-related infections, a history of allergy, and a PIC. And they found that it was pretty common that per 1,000 device days, which is how we measure complications related to various tubes, there were 1.7 events. So mainly irritant contact dermatitis, again, the skin getting irritated, some mechanical skin injury, and then some skin tears. So that pretty much wraps it up. I included a few resources there for you that have more information on some of these topics. The UOAA site has a lot of webinars available. And I think we have just a couple minutes if there are any questions. Or if no general, oh, there's one over here. I was saying that if there are no general questions, again, I'll be available.
So I just have a question about, I have had several PIC lines, and we use the sensitive skin dressing already, but we still have issues where my skin will kind of like look like it's like scaly almost when they take off the dressing. It's like real dry and itchy. So is there anything to do to kind of prevent that?
Like I say, probably the first thing that we always say is just making sure that, so when you take the dressing off and they use some sort of an antiseptic to cleanse the skin, just making sure that that really, really dries. And especially nurses are very impatient.
Yep.
They don't tend to wait, and we say like 2 to 3 minutes, like a real 2 to 3 minutes, not like, oh yeah, that was 2 to 3 minutes. Okay. Really letting it dry so that is not on there. Sometimes there are different types of dressings than what comes in the kits.
Yep.
And so sometimes you can, try a different dressing. Some of them have more moisture vapor.
Oh.
If not, then sometimes they have to go to alternative dressings, which is kind of a last resort because then you don't have occlusive. I mean, occasionally you have to go to like gauze and tape, but then it doesn't protect the site as well.
I'll just have to set my timer for 3
Yeah.
minutes.
And just keep saying,
Thank
no, wait. Okay, well, thank you very much, and enjoy the rest of the conference. And wait, we may have...
Thank you all for tuning in to day 2 of sessions. Just like yesterday, we will be having lunch in the exhibit hall. It'll be like a grab and go. This time we're doing breakout sessions. So at the other side, kind of the end of this hallway, is the Sterling 1 through 5 rooms, 1 through 5 or 1 through 6. And that's where the separate breakout sessions will be, and they will be labeled so you can kind of see where each one will be. And then tonight we also have our wine and cheese social, our teen time, and our jam and jammies. So get excited for those. We're gonna have karaoke too. So go to the wine and cheese first, and we'll see you there.